Now, sometimes the cervix has an unusual shape, known as an hourglass cervix. What happens here is that the cervix is completely distended, but it's not all that dilated because fluid herniates out where the membranes herniate through the external os into the vagina. So now the vagina contains membranes herniating through with fluid, and it has a greater ability to distend than does the cervix. So the cervix may be rather non-dilated compared to the fluid in the vagina. Hence, you get this more or less hourglass configuration. And to those of you who have not seen it before, it might be confusing because you may fail to understand the anatomy. So let's look at this hourglass here, hourglass seen on this little diagram here, or picture. What are we looking at? That is the cervix. And you can see it is not as distended as the fluid that's in the vagina. And when you see this, notice again, we're starting transabdominally. This is a patient in whom you do not want to put anything into her vagina because you might rupture those membranes or you may give her an infection, and that is a disaster. You get on the phone, you call the clinician, you don't let the patient stand up, you send her upstairs on a gurney to be evaluated by the obstetricians at this point. Here's another example. And again, notice how this endocervical canal, which is completely dilated, is not that distended. The diameter is not that great because so much fluid is present in the vagina, which can accommodate this large amount of fluid. Notice also in this case, what's coming into the endocervical canal is the umbilical cord. So that's a really bad situation when you have a cord presentation. And here's another one. Not that dilated, but accommodating a lower extremity and the foot, which is sitting in the vagina. And here are the membranes, again, that you can see herniating into the vagina, containing echogenic fluid. That's not uncommon late in pregnancy. So several examples now to recognize of hourglass cervix, and all done and appreciated with a transabdominal scan, and you do not want to do a transvaginal scan in these patients. So now that we've discussed varying approaches to look at the cervix, some of the problems, we've mentioned the hourglass cervix, let's talk about some of the problems you may encounter. Here's a patient measured on a transvaginal scan, EV, transvaginal, and the cervical length looks fine. It's about 4 centimeters in length. But now it's 2.5 centimeters. Well, what's going on here? That's too short, but that's normal. What is the difference between these two scans? The difference is that this woman, by history, it sounded like she had an irritable cervix. So what we actually did here was we put pressure with our hands on the upper aspect of her uterus toward the fundus, and with our hands we pushed from the fundus in a direction down toward the cervix. We were putting pressure against her internal os, and because it was irritable, her cervix started to dilate, again by the internal os first. So it decreased by 15 millimeters with that fundic pressure. That's analogous to if a woman, again, if she's having a contraction, then physiologically she's putting pressure against that internal os, which is why, as I've already said, at the time of a contraction, go and look at the cervix because it might be getting shorter. If she's not actively having contractions, but you're concerned, see if you can put pressure against it by putting pressure on the fundus and pushing down in the direction of the internal cervical os. So here's an example where the cervix looks relatively okay. Now I'm going to show you a clip as we're applying fundal pressure in this woman. As we do so, you can see how her internal os is starting to dilate and her cervix is getting shorter. What about this patient? This cervix looks fine. It's more than 4 centimeters long. Looks great. But now, within a period of just a couple of minutes or so, her cervix has shortened greatly. And what's going on here? In 2 minutes, it spontaneously decreased. She was having a contraction. She had an irritable cervix. So be aware of this. One other point I'd like to make. When you put the vaginal probe in to do this, don't just put it in and then just pull it out 10 seconds later, because it's just my general feeling that when you first put that probe in, the cervix, if it was dilated, may decide it doesn't like the probe in there, and it starts to go back to a more normal appearance. So when you put the probe in, I would suggest you keep it in it for at least 1 or 2 minutes. Talk to the patient, try to get her to relax, and see if you have a more physiologic appearance to that cervix. Because when you first put the probe in, I think the doors slam shut, and that is something you don't want to have, a normal looking cervix if it's really dilated. So you want to pick up all the cases you can. Here's another example where you might think that cervix looks, it's a little bit of, maybe the letter Y might come to your thought here because of that V-like appearance at the internal os. But look at this cervix. Oh, wow, look at it. It's totally dilated. Well, why is it here it looks okay and here it's so totally dilated? It doesn't look absolutely okay, but certainly a lot worse here. Well, what's happened here is that when that vaginal probe was put in, it was compressing the walls of the cervix. In other words, we were pushing with the probe, compressing the anterior against the posterior wall of the cervix. I'm going to show you a clip in just a second. Here we go. As I push with the vaginal probe, I can push the anterior wall of the cervix against the posterior wall. And I would suggest you not do this because I think if the cervix is already this irritable, it's not going to be happy when you push the probe like this. I also want to mention I am not pushing the probe over and over and over here. This is just one push, but the clip goes around and around and around. Once I see that the cervix is dilated, do not push that probe in so hard that you're compressing its walls. You don't want to have a normal-looking scan when it's not normal. Here's another example. That cervix looks perfectly fine. And if you measured it, it's a normal measurement. Notice also where we put our calipers because it's a slightly curved cervix. So this is a sum of these different measurements. This one plus this one is a normal length cervix. But now you measure the same patient, it's only 2 centimeters. And this is again an effect of pushing too hard against the cervix with the vaginal probe. And I'm going to show you a clip in this case to show you what's going on. Cervix is too short here, and the clip now, as I'm releasing pressure against the cervix with the probe, I think you can appreciate it was longer and now it's shorter. It's longer and now it's shorter as I'm pulling back with the transducer. So don't push that cervix, don't make it look closed or longer than it really is by having transducer pressure against the cervix. What about this case? This is done transabdominally. Now, if you're busy and somebody just shows you this, it might be very easy to say, that looks like a normal cervix. Oh, but now it doesn't. Now it looks like there's fluid in the endocervical canal. So what's going on here? Actually, that's not the cervical wall. That is a foot in the endocervical canal. Here it is. You see it sort of moving just a little bit, and then this baby cooperated, pulled the foot right out of the endocervical canal, and you can see it's a totally dilated cervix. So there are some situations which I'll call a false negative because the cervix looks normal, but it's really not. And you want to avoid these situations. The things, again, to review that could get you in trouble is that overly distended urinary bladder, if the cervix is irritable, but the patient's not actively contracting and you fail to do fundic pressure maneuver, that is pushing your hands, taking them on the top of the fundus and pushing them down in the direction of the internal os. Intermittent dilatation, pushing too hard with the probe, compressing the walls of the cervix, and an unusual situation where there may be fetal parts in the endocervical canal.